Hello everyone, good morning. I'd like to introduce the chair of this B.N Purandare lecture for today, Dr. Nandita Palshetkar, who has done 35 years as a reproductive endocrinologist. She is the past president of FIGO, the IVF and Endoscopy Societies of India. She is also the co-chair of the REI Committee for SAFOG and AFOG, and she is the FIGO representative of FIGO. Thank you, Dr. Palshetkar.
Hi, good morning, everybody. It's a wonderful day, and we are at the end of a wonderful Congress. And I'm here to introduce Dr. Pai and the Dr. B.N Purandare Keynote. Dr. B.N Purandare, fondly remembered as the father of obstetrics and gynecology in India, was a visionary who shaped women's healthcare in our country. A past president of FIGO and FOXY, he dedicated his life to improving maternal health and advancing medical education. His pioneering work set global standards in obstetrics and gynecology, inspiring a generation of clinicians. It's a privilege to honor his legacy through this keynote session. And now to the man who's going to deliver this keynote session. Dr. Hrishikesh Pai is one of India's leading IVF specialists with over 3 decades of pioneering work in reproductive medicine. And to introduce him, he is the trustee of the FIGO Asia Oceania 2325, professor of reproductive medicine, D.Y. Patil University, Navi Mumbai, medical director, Bloom IVF Group, owns 6 and operates 5 IVF centers, president of FOXY 2023, president of the Endoscopy Society of India 2008, president of the IVF Society of India 2014, adjunct assistant professor, Jones University in US till 2023, member of FIGO and Bill Melinda Gates Leadership Group 2023, clinical fellow in reproductive biology at Royal Women's Hospital, Melbourne, 1989, started IVF in India in 1990, done 30,000 plus embryo transfers, did MSc Masters in Clinical Embryology and Andrology, EVMS, Jones 2006. He's the founder chair of the Indian SIG American Society of Reproductive Medicine, ASRM, Assistant Director of External Affairs and Corporate Affairs, IFFS, 2013 to 2021. Organizing Secretary of the IFFS World Congress, India, 2016. Organizing Secretary of Best of Eshrei Isar IFS, September 2024, Jaipur, India. Scientific Chair of the All India Congress of OBGYN in Mumbai. Professor Hrishikesh Pai is also on the editorial board of Global Reproductive Health International Journal of IFFS, board member of the IVF Worldwide, editor of the Indian edition of British Journal of OBGYN, founder editor of the IAG journal JGES, received 67 awards including the honorary FRCOG Fellowship, Udendum College, Royal College of London, UK. In 2019, he received the Eminent Physician Award from the National Indian Medical Association in 2022, 5 Lifetime Achievement Awards endowed officially by societies from the ISSRF, Indian Society of Assisted Reproduction, IOG Satyapal Chairman's Award, Indian Fertility Society, and Academy of Clinical Embryologists. He's delivered 800 lectures, plus 46 plus orations, 44 research papers, and 270 citations. Series editor of 25 Good Clinical Practice Guidelines, GCPR, editor of 38 books and author contribution to 65 book chapters, author of 75 national and international publications. So friends, in the spirit of Dr. B.N Purandare's lifelong commitment to advancing women's health, today's keynote looks at how innovation continues to transform our field. Dr. Hrishikesh Pai, a global authority in IVF and reproductive medicine, will speak on assisted reproductive technologies. The future is bright, carrying forward that legacy of vision and progress. Dr. Hrishikesh Pai. on this one.
Thank you, friends. I would like to, first of all, thank the organizers for giving me this privilege of delivering this lecture, which is very important. Dr. B.N Purandare was my father was from Harvard University. He was master's in public health, and they were very good friends, and they did a lot of pioneering work. So it's a privilege to deliver this lecture. So if you there's a standardization of care as far as I think I'll have the laptop because I can't see properly. There's a standardization of care, and the pregnancy rates have increased over the last 10 years. You know, there's this study from United States where they had studied, it was a comprehensive survey of 13 IVF programs performing IVF, and the rates of pregnancy have really gone up by 25%. So the present rates are jumped from 35% to 60%. So in 3 attempts, nearly 90% people now achieve pregnancy. So there is quite a lot of breakthroughs as far as IVF is concerned. But with the IVF, there's a lot of increase in ancillary services. So we have got, and these services have led to higher growth. We have got counseling, 3D ultrasound has come in a big way. Sonovac ultrasound is being used a lot. Endoscopic surgeries have gone up a lot. PRP and stem cell, especially for poor responder patients. High-risk pregnancy management, because many of these patients have multiple gestations, and because of that there's preterm birth. So high-risk pregnancy management services, NICU, PICU services, and genetic services all have really, so IVF has boosted a lot of other ancillary services around. It has also, regulations and compliances have also accelerated the growth. So we had the HFEA regulation in 1991, and in India we have got a regulation now in 2021. And a regulation, initially always people say, oh, if there's a regulation, there'll be a problem. But regulation has a lot of advantages. It increases ethical and safety standards. There's a higher increase in trained personnel, good equipment, affordable, accessible services, transparency, accountability, record keeping. It minimizes malpractice, protects the rights of donors and surrogates, and there is a clarity in legal resource. So it builds trust between patients and doctors. So regulation, in fact, is a very good booster as far as the services are concerned. Minimizing complications has led to patient safety. So our thrust in IVF has been to how to reduce the complication rate. When I started IVF in 35 years back, we had the GNRH long protocol, and there used to be a lot of hyperstimulation. People used to go into ICU, we had to tap the patient, we had to do pleural taps, abdominal tap, but with antagonist cycle coming in and a GNRH trigger. So there's a segmentation protocol which has been brought in, and the hyperstimulation risk has nearly gone down to 0. So that, and in advancement in oocyte retrieval techniques, when I started IVF, it was endoscopic surgery. Now we have gone to transvaginal ultrasound. So it become very easy for us to conduct the programs. There was a WHO infertility prevalence estimate analysis in 2023, which had studied 133 studies. They surveyed 12,241 studies which were published between 1990 and 2021. And they selected 133 studies, and they found that the prevalence rate has really gone to 17.5%. So initially, IVF was looked as, okay, it's not an important healthcare problem, it is 5%, but actual prevalence rate is very high. And Pascal Alote of WHO has said that millions of people face a catastrophic healthcare cost after seeking treatment for infertility, making this a major equity issue and all too often a medical poverty trap for those affected. So it's very important to understand that participation of NGOs, ministries of health has enabled health equity, because ultimately we don't want only well-off people to have access to IVF. We must also look at our important chunk of people, and advocacy, public financing, integration of infertility services with the government insurance policies, competitive pricing. Even private sector has become very competitive now. Pricing has really, so market forces are controlling the price. Interest-free loans are available in our country. Insurance cover is increasing. So all these things have resulted in better access and better health equity. Ethical clarity has increased utilization of services. So we have egg donation services. Now with the regulation, there's more clarity. Certain countries, they don't allow what is known as third-party services, but the clarity has come what you can do and what you cannot do. So this is very important for the industry as such. Medical tourism is propelling economies and enabling patients to achieve their goals. So there are different types of tourism. There is something called an intra-country tourism. Within our country, we have 31 states. Some of the people from rural areas can come to cities to get treatment. So we have intra-city tourism, intercity tourism. Then we have inter-country tourism. We get a lot of patients from abroad into India for various services. And some of the services, for example, there are certain services that are not available in India. People are going towards the Middle East to get those services. So cross-border tourism is a big thing at present in the IVF space. Awareness building has led to increase in the demand. So community outreach programs, television and print media, digital media, websites, Google, Instagram, Facebook, WhatsApp, ChatGPT, all these things have made it more accessible. And there's a new program from the International Federation of Fertility Societies called the More Joy program, which was actually started by Professor Makano from Ireland when he was the IFFS president. And it's really become a very good program to actually promote IVF as such. New innovations and breakthroughs are sustaining growth. So we have a lot of fertility and IVF predictor apps. We have new therapies like vaginal microbiome transplant, tacrolimus for recurrent IVF failures, stem cells, NAD therapies, artificial intelligence in sperm oocytes, embryo selection, automation in the lab, robotic XC, automatic vitrification, time-lapse imaging, dynamic cell culture. So there's a lot of new things that are, when I took this line, actually, when I was, when I finished my graduation, I was quite bored and I wanted to take a new line. And I really went into this line in 1990 and it's a line that never looks back. It's always evolving. So there's a lot of new things and I wanted you to get an insight into what's new in this field, which is such an exciting field, you have no idea. So we have a lot of things, and I'm going to go through these things very quickly for you. So one of the things that is very important to see is that there's an automatic sperm analysis. Initially, when I came into practice, there was a CASA, which was very costly, nearly $30,000. Now we have this. It's a cloud-based. It just costs about $1,000. You just take a drop, plug it in, and you put it in the machine, and the machine gives you exact answer because it's very important. The semen analysis step is a very important step. If the pathologist by mistake gives a wrong analysis, you are going to make a mistake and you are going to tag it as a non-male factor infertility. So it's very important that the machine is there who will try to find out and tell you, no, Dr. Pai, this is a male factor infertility. A human can't do it. You have to have a cloud-based system to actually pinpoint that, and that's easily available. You can easily get it nowadays. The second thing that has come in is sperm preparation techniques and microfluidics. So, normally we used to do double density. So, okay, many of you may not know what is IVF. So let me tell you, if an infertile couple comes to you, for 2 years, you just try for a natural pregnancy. If that fails, you start investigating the patient. You do her, normally I do an AMH level. I do a prolactin, thyroid. I will do a 3D ultrasound to see if there is any major problem in the lady. As far as the guy is concerned, I would do a semen analysis. So by that, I can differentiate. Once I do that, I try to look for the tubal patency. If the tubes are patent, I will offer them 3 cycles of intrauterine insemination. And if that fails, I will do IVF. IVF, normally we do 3 times. In 3 attempts, about 80% people will become pregnant. In 3 more attempts, about 90% people will become pregnant. So in 6 attempts, 90% of people will take a baby home. If there's a low count, instead of doing standard IVF, I'll do a micro injection and try to, so this is the standard protocol. So when we are doing IVF, we have to take the sample and process it. That processing of the sample, then we have to fertilize the oocyte. That processing normally we used to do by double density gradient or centrifugation. But now the new breakthrough has come where we just put it into the cartridge. It's called microfluidics. We just load the cartridge, and within 40 minutes, the sperm extraction takes place. Through microfluidic channels, the good quality sperms will swim down and the extraction will take place. So then we have the ICSI, that is the intracytoplasmic sperm injection, where you can actually take the sperm and inject it into the thing and achieve the pregnancy. Then we have the SID, which is another automated sperm selection technique where now, when we are doing micro-injection, we can just connect to the internet and we can find out whether there is the machine within artificial intelligence, it selects the sperm as you are doing the micro-injection. It tells you which sperm to pick up and inject. And the SID is a very good technology where you can see here the machine is grading the sperm. You know, the SID is based in Mexico. It automatically, as you're injecting, machine tags the sperm and you can go and inject the sperm. Then we have the new fertilization technique, and this is called piezo. Of course, the Japanese have been using it for a long time, the piezo ICSI, where you can, so instead of using mechanical injection to do micro-injection, you use a vibration. So the hole that is created in the cytoplasmic membrane is very thin, and you can directly inject the sperm without damaging the oocyte. So piezo has slowly started replacing the standard ICSI procedure in our tech. Then the big thing that has come in is robotic ICSI. It's a huge breakthrough. First babies have been conceived with automated ICSI. Nino Costa Borges, my friend, has done it in 2023. And the automated injection pipette advancement, zona pellucida, ulna penetration is done with piezo. I showed you the piezo ICSI technique and the pipette removal after sperm release. The ICSI robot was controlled by engineers. So in this paper, the engineers were trained to do the ICSI rather than the embryologists, and the engineers performed better than the embryologists. Imagine that, because, and 2 singleton babies were born. So this is a huge breakthrough. The other challenging area of male infertility is non-obstructive azoospermia. So in non-obstructive azoospermia, there are certain people who have little bit of sperm activity going on in the testes. So nowadays we use an operating microscope, and using micro TC, we can magnify the image and we can pick up the sperm. We also, but when we take the biopsy and we are looking for the sperm in the biopsy specimen, it takes about 3-4 hours. The embryologists become very tired in looking for the sperm. So we have a new technique that has come in now. This is an automatic technique where the artificial intelligence, as you are searching for the sperm in the field, the machine tells you where to go and pick up the sperm. By looking at the morphology of the cells in the testicular tissue sample and slight movement, machine will tell you, go there and look for the sperm. So that's a real good breakthrough that has come in this technique. The other area of improvement is in the cryopreservation. So there are enhanced ultra-rapid protocols, higher survival, automation of freezing process, and social freezing, etc. Now the cryopreservation, when I did my fellowship in Melbourne in 1990, we used to do the slow freezing TSAT technique. But in 2007, first time I went to Tokyo, and that's one of the biggest IVF centers in the world. It is called Kato's Lady Clinic. They do 17,000 cycles a year. So there I was trained in the technique of vitrification, which was a breakthrough technique. With vitrification, the survival rate has gone to nearly 90. So suppose you freeze an embryo, you retrieve the embryo, the survival rate is nearly gone to 90%, 95%. Just imagine, once upon a time, the survival rate was 50% when I started doing work in Melbourne in 1990 using the slow freezing with the vitrification. So this breakthrough has revolutionized freezing, revolutionized IVF industry as such. So there are 2 types of fertility preservation now we offer the patient. One is there is the egg freezing. So you take the oocytes and you freeze the oocytes for future use. If suppose patient is having cancer She undergoes chemo radiation therapy. She's young. You can first take out the oocytes and then give her the chemo radiation. After she recovers, then after 5-6 years, she gets married or she wants to have a kid, you can take out the frozen oocytes and give her a pregnancy. The other technique is ovarian tissue feeding. We don't have time. She has got breast cancer. The oncologist is saying, tomorrow, doc, we need to get her on chemo radiation immediately. Then we go in with a laparoscope. We do a hemioophorectomy, remove the medulla and freeze the cortex. So that's a technique what is known as OTA, ovarian tissue freezing. So there are a lot of indications of these two techniques, and one of the main breakthroughs in this area, so egg freezing everyone does, but one of the breakthroughs that came was spindle check. So we look at the eggs and we see whether the spindle has formed. If you freeze the oocytes, after the spindle, normally spindle formation takes place about 2 to 3 hours after the oocyte retrieval. If you freeze the oocyte, after the spindle is formed, then our recovery rates are very good. So the recovery rates are very good if spindle is formed. Similarly, when you thaw the oocyte, suppose after 7 years, patient comes back and I thaw the oocyte, if I wait for the spindle to reform and then I do intracytoplasmic sperm injection, my pregnancy rates are very high. See, this is a very precious resource. Patient has come to you, you have frozen 9 oocytes. Now you want to give an embryo and a pregnancy out of those 9. She has come back after 9 years to you. You take out her oocytes. You have to be very precise to get that embryo. So the spindle formation, if it is not there and you do ICSI, the results are very bad. I wanted to show you this wonderful technique where you can see the white dot at 12 o'clock, that's the spindle. Look at the technology. You can actually see the chromosome spindle while you are doing the microinjection. That is the power of technology that we use in our laboratories nowadays. So the other thing that has come in our field now new is automatics, because when I went to Cato in 2007, when I came back, I did freezing for 4 years myself. I didn't want to teach anyone the technology around me. And it's a very skill-based technology. You have to be very good at loading the straw, etc. But now it has been replaced. You just put the oocytes in the dish, machine picks them up automatically and freezes them. So machine. So I feel that if you look at robotic surgery also, the machines are they are democratizing medicine. If you're not a great surgeon, the robotic surgery will make you a good surgeon, because the machine is titrating your movement. Even if you are having tremors, you are going similar. So machines are slowly going to replace humans in a lot of fields, in our fields. So I just wanted to show you how we do the freezing of the ovary. So if we do a hemiophorectomy, we'll take the ovary out, we'll dissect the ovary, remove the medulla, then have a very thin cortex and then make small pieces of this cortex and vitrify these pieces. After we vitrify it, after let's say 5 years down the line, she has had her chemo radiation, she's come back, what we do is we create a window and we put those small pieces back into the pouch of Douglas. We can create a peritoneal window, or that's why we do semi-oophorectomy, because in hemi-oophorectomy, we have a part of the ovary remaining behind, so we can embed the cortex pieces into the ovary again. So this is a technique we use for embedding. So the other area, very exciting area of our line is embryo selection. So why do you want to do selection of embryos? Because now what we have realized is that if there are, let's say, 4 blastoses, we can put 2 blastoses and get a very good pregnancy rate. But then 25% will land up in twin pregnancies. They'll have preterm birth, they'll have cerebral palsy, they'll have deafness, etc. So there's a lot of complications of multiple pregnancies. Can we, out of those 4, select 1 blastocyst, put it back and get the same pregnancy rate as we would get if we put 2 blastocysts back? So that's where the selection of embryo comes in. So embryo selection is very important for us. So in the embryo selection space, there are other also indications of embryo selection, but one of the standard selection techniques is pre-implantation genetic testing. You have the trophectoderm, you do the biopsy, you freeze the blastocyst, you send the 4 cells to the lab, they do a next gen. There's a new technique, it's called NGS, next gen sequencing. You do the whole genome amplification, then you do the analysis using an NGS, and then the report will come. Out of the 4, blastocysts 1 and 3 are normal in genetics. So you select one of those blastocysts, you do the transfer, and you will be surprised the live birth rate after transferring a euploid, that is a genetically normal blastocyst, has gone to nearly 65%. So it's a really good technique of blast. So this is how we do the trophectoderm biopsy. The original technique you can see on the left-hand side was the blastomia biopsy on day 3, but the new technique is to do the trophectoderm biopsy and then do the analysis. The other exciting field is non-invasive testing. So I went to Shanghai just prior to the 2019 conference in IFFS. China is a massive country. The technology advancement in China is unbelievable. And I went to Shanghai to train in this technique in 2019. I went to 2 hours drive outside Shanghai, a huge 9 genetic sequencers. Normally, I have got 1 sequencer in my life. They had 9. They were doing 50,000 sequencing per month. Just imagine the throughput which was there in that. And this is the new technique. It's a non-invasive testing. So in trophectoderm biopsy, you take the biopsy of the trophectoderm, amplify the DNA. Here, what we do is, as the embryo grows in culture, the DNA is perfusing into the culture media. You take the culture media and amplify the DNA using whole genome. And there's a technique of amplification. It's called Malbac. It's a new technique where you can do fine amplification. Because when you're amplifying, you can even amplify the cumulus cell, or you may amplify the skin cell of the embryologist. So you have to be very careful as to what DNA you are amplifying. And then you can do analysis. So in PGT, you can do a single gene analysis. You can do, if there's a recurrent abortion patient, you can do what is known as PGT-SR for recurrent abortion. If there's a aneuploidy testing, you want to select the best embryo, it's called PGT-A. You can do, no, but the new breakthrough that has come in is the biogenic analysis. So what has Nathaniel Treff from UK did this, he did a biobank analysis. So what he did, he created analysis of diabetics, cardiac patients, and stroke patients, and found certain combination of genes that can predict that this baby will have a higher chance of diabetes. So now when the embryos are formed, you can do a biopsy and do a polygenic analysis and predict which of these embryos, if you put back, will have a lesser chance of diabetes. So that is the next step of our technique. The other thing that has come in a huge way is artificial intelligence, and AI is there everywhere. I started using AI in my lab 4 or 5 years back. So I do AI for the oocytes, I do AI for the embryos, I do AI for the sperm. So artificial intelligence is a part and parcel of our system at present. And it, of course, has a very good, it predicts implantation potential in embryos. It enhances decision making for successful rate. So I wanted to show you one of the techniques of artificial intelligence. This is the artificial intelligence of oocytes. So a lot of patients that come to us for fertility preservation for the future, the question they'll ask you, Dr. Pai, can you tell me how many eggs should I freeze so that I have a good chance 10 years down the line? So normal answer is 10 to 12, 14 eggs if we have. But now we can dissect the oocytes, we can immediately take the photographs, and we send them to a server in Canada, and the server tells you in 2 minutes whether the eggs are good enough for a pregnancy 10 years down the line. If the eggs, the AI says that no, the chances are less, we can counsel the patient to have one more cycle and freeze the extra oocyte. So this is a major breakthrough that has come in the artificial intelligence space, and we use it regularly in our labs at present. The other AI system which is come, and it's a big breakthrough, is the world's first AI-driven ICSI baby has been born just now. So it was done from United States. They controlled the baby in Mexico. All the ICSI, 23 ICSI steps were done using AI from remote control. And they got the first baby. It's a fantastic technology. You can see here. I just picked it up from the paper of Cohen et al., RBMO on 2025, and you can see the artificial intelligence is driving everything. You can see the automatic, everything is done by the machine. We are not touching it at all. So this is a big breakthrough that has come in. The other area, though in our practice, there are 3 groups of patients that come to us based on the AMH. So automatically we classify them on AMH. We do the anti-Mullerian hormone test. Normal is 2 to 3.5. If it is more than 3.5, it is known as hyper responder or your PCOS patient. Between 2 to 3.5 nanogram per ml, it is a normal responder. And less than 1.5 nanogram per ml is the poor responder. Our problem child is the poor responder. In normal responders and hyper responders, the pregnancy rates after 3 attempts are nearly 85-90%. We are not, if I get a hyper or a normal responder in my practice, I'm very happy. There's no problem at all. But the poor responder, 0.3 mH, 0.4 AMH, so I said, my God, what do I do? So there are a lot of techniques, the ovarian rejuvenation technique, because the one option is to ultimately ask them to go for egg donation. But I was trained in Eastern Virginia Medical School. I did my master's there, and the father of IVF in United States was Howard Jones, and I was fortunate enough to work with him. At that point in time, he was 100 years or so old, and he gave a talk once, and he told us that there are 3 things that patients hate in IVF. They don't want to have a donor egg, they don't want to have a donor sperm, and they don't want to have a donor womb. They don't want a surrogacy, they don't want an egg donation, and they don't want a sperm donation. The future of IVF would be to replace these 3 with their own DNA. And so ovarian rejuvenation therapies are one step before we go for egg donation. So we can inject PRP, we can inject stem cell, but they are fringe therapies. Some people do become pregnant with these therapies, but most of them, you can do autologous stem cell injection using laparoscopy. You can use stem cells from bone marrow, adipose tissue, or hematogenic cells and try to improve the outcome. The other area which I wanted to show you is the spindle transfer. So metabolic disorders is a big problem. And when a person has a child with metabolic disorder, then the next baby, they don't want the mitochondrial disorder. So there are 2 techniques which we do in IVF. One is called the spindle transfer. So what do we do in that? The cytoplasm is having the problem. The genetic problem is in the cytoplasm mitochondria. So what we do is we take a donor oocyte, as you can see on top, and we enucleate the donor oocyte. So I showed you the spindle check technology where you can see the spindle. Using the spindle check and using the piezo, we can go in and take out the donor oocyte. Then we take the actual patient's oocyte and take the nucleus of the patient out, and then we add it to the enucleated donor oocyte and create a new oocyte with the cytoplasm of the donor and the nucleus of the patient. So the mitochondrial DNA is eliminated, which is affected DNA, and at the same time the DNA is of the actual mother. And then we do micro-injection, and the first babies, live births, were born by Nuno Costa Borges. He had a paper in Fertility Study in 2023. But so instead of doing, because for this we need a high level technology. We need a spindle check technology, we need a piezo. So there's a high level technology you need. Instead of that, what the others are doing is they fertilize. So they take the donor oocyte, fertilize it with the donor sperm. They take a patient oocyte, fertilize with their husband's sperm. After 24 hours, both of them develop pronuclei, which are visible. So you don't need a spindle check technology to see those pronuclei. Then you enucleate the pronuclei, take the patient pronuclei, put it into the donor oocyte, and then create a new child. And first, the McFarland in New England Journal of Medicine, just a few months back, they have reported from England 8 live births, and it was an exciting thing because I'm waiting. See, I have done all the technologies. Till now, when I talk in a lecture, I don't like to talk theory. I like to do practice. All that I've told you, I practice in my lab. But I'm waiting for this technology. I want to go to England. After I finish my trustee job, I finished now. I'll go back to school, go back to England, learn this technology and bring it back. Very exciting technology. So I want to show you the technology as they did it. It's from their journal, which I picked up. This is the removal of the first pronuclei. Video is from McFarland et al., New England Journal of Medicine. So you can see the pronuclei. We have cut the zona with the laser now, and we'll put the needle in, and we'll aspirate both the pronuclei out. So enucleation of the pronuclei. You can see them gently, you can aspirate. So the pronuclei is where the chromosomes are. Okay, so the DNA is. So we don't want the mitochondria to come with our aspiration. We just want so both the pronuclei are aspirated, and then putting the pronuclei into the enucleated other donor oocyte. So you can see that first is the removal, which you have done. Now let's see the putting back. So this is the enucleated donor oocyte, where the two pronuclei are enucleated. Now you take those which you took out from the mother and then put them back. Now, how you will say, Dr. Pai, how do you fuse this? How does it happen? So we expose them to it's called Sendai virus. So there's a Sendai virus. Its capsule extract is, so before you put the pronuclei on, we expose them to Sendai virus and then put them pronuclei back into, so the Sendai virus fuses. There's a capsule which has got various antigens which enables the fusion of the cytoplasm with the pronuclei. So this, and then of course, so that's the way you do the technique. The next thing is uterine transplant. So like, the IVF group has never been very favorable about uterine transplant because we always feel that suppose, kidney transplant I'm okay with, but a uterine transplant for a child, if something happens to the donor, what if the donor dies? It's not justifiable. So I was quite skeptical about uterine transplant, and that's why if you see, total births are about 50 to 70 in the last, even though Mats Brandstorm did a fantastic job from Sweden, but we as a community are not kind of favorable with uterine transplant. But the breakthrough has come in uterine transplant because now you can do cadaveric transplant. So, okay, cadaveric transplant, and it's very easy because in the cadaveric transplant, you anastomose the external iliac. In the live uterine transplant, you have to do dissection. It takes about 10-12 hours. You have to dissect and anastomose the internal iliac vessel, which has a very small diameter. But in a cadaveric transplant, you take out the uterus and anastomose the external iliac, which is a huge diameter vessel. So it's better, and the first cadaveric transplant babies have come from Brazil. One of the Brazilian group has done the cadaveric transplant, but I'm still not happy. I think that's giving too much extreme. I might well tell them to adopt a child and not go for the transplant. This is my personal opinion. I don't have to. The other thing that has come is biomechanical womb. So ultimately, baby will be born outside the body. It's called exogenesis. And this was first described by Aldous Huxley in 1932. He published it and in the Brave New World, and now it may become a reality. So with the artificial intelligence and 3D printing of the placenta coming in, and in England they have now, I have come to know that there was a moratorium of research. So there was a block which was put at 7 days. So you can do research on embryos till 7 days. Now that block has been lifted and you can do research till 14 days. So actually you can grow the embryo for 7 days more and come to the best embryo, best analysis, and then put it in a 3D printed placenta with all infusion systems of carbon dioxide, oxygen, temperature fluctuation, and using AI. Artificial intelligence to control the external womb. That is now a major possibility, and within, I think, 5 to 7 years, we'll have a baby born in the outside. That was not possible. I always used to talk in my lectures that it will happen maybe 30 years down the line. Now, no more. With the AI, it will titrate all the gases, it will titrate the nutrients, and it will keep the child okay in the external womb. The last thing I wanted to tell you was reprogramming of skin cells. And that is a big, big, big breakthrough which has come in. And this work was done by Yamanaka in Cell 2006. He got the Nobel Prize in 2012. So he reversed the skin cell. It's called, you take a skin cell and you can reverse the skin cell and make it a stem cell. It is called induced pluripotent stem cell, iPSC. So using 4 transcriptomic factors, you can inject the factors. So how do you inject transcriptomic factors into a skin cell, you use a retrovirus. You tag those transcriptomic factors to a retrovirus and infect, it's called transfection of the cell, and you put these transcriptomic factors into the skin cell, and those factors reverse it. Imagine, they reverse, and because you can't take a other person's stem cell because there'll be graft rejection. You have to create your own stem cell. So you do it by reversal. So in the future, and then you haplodize it. So the skin cell, you reverse to a stem cell, then its chromosome is 46. But sperm and oocytes are 23. So there's a haplodization step. You have to do a meiotic division, bring it to 23 chromosome, conversion of that cell to sperm or oocyte. So in the future, we'll be able to. So Professor Jones had told us there are 3 things people hate. They hate a donor sperm, a donor oocyte, and a donor womb. The biomechanical womb will replace the surrogacy as a technique. The skin cell reversal will replace donor sperm, and the skin cell reversal to the oocyte stage will replace the donor oocyte. So in the future, we'll have the patient's own DNA. The final thing I wanted to tell was CRISPR. So the CRISPR is clustered, regularly interspaced, short palindromic repeats. It's called, and this breakthrough was done by Emmanuel Charpentier and Jennifer Doudna. They got the Nobel Prize in 2020 for chemistry. It's a major breakthrough. You can apply to multiple medical lines, and you can actually, so in the olden days, what used to happen, the thalassemia, let's say there's a couple with 2 thalassemia carriers are there. I do the IVF, I do the analysis. There are some of them are having both thalassemia genes have come in, so they are dominant. I discard the embryo. Now, using CRISPR, you can correct that thalassemia and not discard the embryo. So we can go towards what is known as constructive genetics. At present, genetics is destructive. I diagnose something and don't transfer it, or you diagnose an abnormal baby and you try to do termination of the pregnancy. But now you can do correction of the embryo. Instead of discarding the embryo, you can correct the embryo. The problem with CRISPR is that there is what is known as multigenic targeting. So there are certain DNAs which may target. You may try to target a thalassemia DNA, but in the process you may target some DNA which is similar to that. So it's called off-targeting. So, but the scientists are becoming better and better, and they are focusing the targeting, and at some point in time, when the targeting is very specific, they'll allow the CRISPR embryos to be put back into the womb. At present, there is a moratorium. We are not allowed to put back the CRISPR embryos back because we are not sure as to the outcome of the children. The last thing is the access to care. So this is my most important slide, and I believe I got, me and Nandita are partners. We have got 11 centers, and I was telling her one day I'll do a free IVF. I mean, because in our world, there are so many poor people, so many not so well-off people, and we must give them. And the only way, I tell everyone, how do you give that equity? You can give that equity only by not charging your fees. You have to and I feel that's the power of a doctor. We have the power to give things free of charge. That is our power. That power no industrialist, no businessman can give. And that power of giving, we should have all the time in our life. So that is the access to care is very important. So in conclusion, a big thank you to FIGO, first of all. And it's important to balance innovation with safety and equity. All these are innovations, but all the time we are worried. Are we making a problem? Is there a problem? If I do the biopsy of an embryo, select the embryo, am I, because of so many interventions, am I creating a child which will have a less lifespan? Am I creating a child which will have a higher cancer potential in the future? So, I always believe, I tell all my students, I said, listen, any intervention, don't focus on the pregnancy rate. Focus on the safety. Are you creating a baby which is safe enough? So this is very important. We need to adhere to national policies, which also need to evolve with time. We have to keep on evolving. We can't get stuck on ethical. What was unethical maybe 20 years down the line becomes ethical maybe 20 years hence. So it's very important. And we need to regulate, keep evolving regulations and guidelines, as I was telling you, because there are new technologies coming in, polygenic risk scoring, gene editing, gamete creation, exogenesis. So they are all new things. It's a very, I was always worried to talk to an audience. A lot of you are into general obstetrics, and I didn't know whether you would like this talk or not, but this is the future. And in our country, for example, when I started doing IVF, there were only 10 of us. I started in IVF in 1990. I came back from Melbourne, Australia, where I did my fellowship, and I started IVF. There were only 10 of us. Now there are 5,000 centers doing IVF. That evolution has taken place. So what I have seen, the evolution, we all started with obstetrics when we were students. Then we branched out into high-risk obstetrics. Someone went to endoscopy, someone went to IVF. And now the newer generation in our country does everything. You have to do everything. It's come back to full circle. And of course, we have to keep on doing maternal health as well. So FIGO is maternal health, but I feel more balance needs to come so that we have a lot of technology coming in the future. Because once we have the technology, then we as physicians become powerful. We have to keep on evolving and keep on changing with the time and keep on reinventing ourselves. I would like to thank all of you for a patient hearing. Thank you.
Dr. Pai, that was very, very beautiful talk. And I think if Dr. B.N Purandare were alive today, he would be so excited listening to you. We have some questions. We have about 12 minutes on the clock. And if anybody wants to ask a question, yeah, I think we've already got a line. Okay, great. Please go ahead. Hrishikesh there.
Yeah, thank you very much. My name is Sam Martin from Ghana. And this is exciting, listening to you and all the new innovations that are coming up. My first concern is, so at what point are we putting the brakes? And there is, especially in less regulated areas, there is a tendency to overstep. What are the guiding principles to say, oh, this is where we must end, this is where we must go? My second one is on the spindle. That I think it's exciting knowing that if you can pinpoint these spindle fibers within the oocytes, the chances of getting live birth or pregnancies are high. In that case, will you recommend delayed freezing of these eggs? Thank you.
Oocyte freezing. Should you do it in patients?
Yeah. Oocyte, you are asking about food.
Second question.
The second question is about oocyte freezing. I didn't understand the question.
Yes. I'm asking, in this case, will you recommend delayed freezing of these oocytes after pickup? Yeah. The oocyte freezing for fertility preservation you're asking about? Yes.
So we do it, we have been doing it since 2007 now. We have done nearly 25,000 oocytes we have frozen, and a lot of patients have come back for pregnancies. But the cancer patients who undergo freezing, coming back for pregnancies around 7 to 10%. So there's a lesser amount of people coming back for cancer after cancer treatment.
What was the first question?
Okay, so my first question is, what would determine putting the brakes, especially when it comes to a lot of these innovations, because of the ethical concerns and the problem with safety? And at what point do we say this is too much for us as humans?
No, so I don't think, so all these are long-term studies have been done and there's no problem at present. So whatever technique, so like for example, the CRISPR technique and all, we are not yet sure about it, so we would not put the embryos back. Even suppose we create embryos from but the PGD, so there are two types of techniques to analyze the embryos. One is the PGD, that is a genetic technique, and there's also so big problem is that we can't predict autism and we can't predict imprinting disorders. These are two areas where the tests are not that easy.